My name is John Masterson, and today I'll be discussing the topic of erectile dysfunction. As I mentioned, my name is Dr. John Masterson. I'm a urologic surgeon and a reproductive urologist with Brandywine Urology and the ChristianaCare Health Network. We are located in Newcastle, Delaware, and Middletown, Delaware. I completed my medical school training at the University of Miami, my residency training at Cedars-Sinai Medical Center in Los Angeles, and my fellowship in andrology, sexual medicine, and reproductive urology at Weill Cornell and Memorial Sloan Kettering in New York. So here we have some resources for erectile dysfunction from Boston Scientific. There's information here about erectile dysfunction in general, some different treatments, and specifically about penile prosthesis, which we'll talk about here today. So some learning about erectile dysfunction. Erectile dysfunction is defined as the persistent inability to achieve or maintain an erection that is firm enough to perform sexual intercourse. And it is a quite common disease state. About 1 in 5 men age 20 or older suffer from some form of erectile dysfunction. And that number increases to about 50% of all men over age 40. So it does tend to be a disease of aging. Just some physiology about the erection process. With initial arousal, there are nerves around the penis that become activated. There are muscles that relax, both in the penis itself and within the blood vessels in the penis. And this allows blood to flow into the penis. Additional blood flow on top of this causes the penis to stiffen, and the erection itself can compress the veins around the penis so that blood doesn't leave the penis. So blood can sort of trap and stay in the penis to stay erect. Some of the more common causes of erectile dysfunction are, sort of impact the things we talked about. So the most significant risk factors are age, smoking, diabetes, hypertension, dyslipidemia, depression, obesity, and a sedentary lifestyle. All of these things can affect, the nerves and blood vessels and muscles that are crucial to erection physiology, like we just talked about. So as you can see from this graphic, the vast majority are from vascular diabetes causes, and then additionally medications and things like that. So, and it's important to note that erectile dysfunction is not just a medical issue. It can also affect relationships deeply as well. ED can also affect people psychologically tremendously. Men who experience ED can experience anxiety, depression, low self-esteem, and overall decreased quality in life. And men with erectile dysfunction tend to be emotionally and physically withdrawn from their partners. And this brings us back to our first slide about the AMS 700 penile implant. So we'll talk a little bit more about this later when we talk about treatment for erectile dysfunction. But men who have erectile dysfunction tend to have low quality of life scores, and men with a penile prosthesis, going from having no erections to having erections, those quality of life scores tend to improve tremendously. And you can see that 95% of patients are satisfied with their intercourse afterwards. And 95% are satisfied with their sexual activity after having this surgery. And 97% of patients who have this procedure done would recommend this to their friends and family. So specifically and more relevant to our talk today is erectile dysfunction prostate cancer treatment. So when we talk about prostate cancer treatment, we generally think of surgery and radiation. So surgery to remove the prostate, or radiation to basically kill the prostate with radiation. So now standard of care is to perform usually a minimally invasive prostate removal surgery with what is called a nerve-sparing technique, where men are able to preserve their erectile function over the long run, but sometimes it can take up to a year for that erectile function to return or kind of establish its new baseline. The nerves and some of the blood vessels that supply blood to the penis for an erection are very close to the prostate, and we do our best to kind of peel them off of the prostate, but sometimes they get injured during prostatectomy. And it's important for people to know that should erectile dysfunction persist after that year, there are many treatment options. So this is just a little bit of an anatomic graphic of what happens during prostate removal or prostatectomy for cancer. The prostate not only surrounds the urethra, but it is part of your urethra. And that is basically removed, and then the urethra is attached directly to the bladder. And those nerves and blood vessels that supply the penis run very close to that area, and sometimes they are inadvertently injured or they have to be injured because they're involved with cancer. So, like we mentioned, up to 75% of men who, even if they do have a nerve-sparing radical prostatectomy, will experience some level of erectile dysfunction afterwards, and it can take about a year for erections to recover or kind of find their new level of recovery. But there are options for men in this situation. So, what are the kind of standard treatment options for erectile dysfunction, and who is qualified to offer these treatments? Um, Generally speaking, a primary care doctor, a family doctor, who has an understanding of erectile dysfunction is, that is an appropriate provider to prescribe oral medications for erectile dysfunction. Urologists also frequently prescribe those medications. Sometimes we can prescribe a little bit more advanced medications like injection therapy for erections. And then ultimately, the prosthetic urologist or an erectile dysfunction specialist is the one who would ultimately help you, help guide you through that next level of treatment, which may involve surgery and a penile prosthesis. So going through the ED treatment options, this is kind of a left to right escalation of intervention. There's oral medications, vacuum erection devices, injections, and then the most invasive would be penile implants, and we'll kind of talk about these individually. There are also, before we even go to medication interventions, it's important to know that, certain lifestyle choices and activity choices can help erectile function. Generally speaking, anything that's good for your heart is good for your penis and is good for your sex life. So, smoking, giving up smoking, losing weight, increasing physical activity can help patients maintain or regain sexual function. And psychotherapy can be helpful as well. Psychogenic erectile dysfunction can be very hard to treat, and there usually is not a medication that we can just throw at patients to fix that. So it's very important for patients who have erectile dysfunction in situational conditions or performance anxiety and things like that. So oral medications are generally a class of medication called phosphodiesterase 5 inhibitors. They work well. There's a few different kinds. Sometimes we'll use them in combination with each other. This is kind of Viagra, Cialis. The most common side effects include headache, facial flushing, and upset stomach. And it's important to note that men with diabetes specifically are more likely to fail these medications and have to move on to more advanced interventions. And vacuum erection devices basically work by creating a negative pressure chamber around the penis and drawing blood into the penis that way. And then they are almost always coupled with a constriction band that you kind of slip onto the penis off the tip of the device to trap blood in the penis, mimicking how those veins would trap blood during a natural erection. There are pluses and minuses of a vacuum erection device. They can, because it kind of creates that constriction band or constricts the whole penis urethra apparatus. If your ejaculate, is trying to travel through your urethra, it can be blocked by the constriction band. It can also cause bruising, discomfort, or numbness because there's not kind of natural blood flow there. And patients who stop using constriction bands and vacuum erection devices usually do so because they can't maintain an erection that's hard enough for penetration, or they just have pain from the device. Another erectile dysfunction treatment is intracavernosal injection therapy. This is basically injection of a vasodilator medication directly into the penis. It tends to work pretty well in most patients, but it does come along with sticking a needle into your penis, which can cause pain. There's always concern with overdosing and ending up with what's called a priapism or a prolonged erection. And most people stop using these medications because they have a poor response, or they just don't like doing it. They don't like having to, draw up a medication and inject every time they want to have sex, or it can be potentially too costly. And then finally, the most definitive but most invasive intervention would be a penile prosthesis or penile implant. Um, it's implanted into the penis, and we basically replace or destroy your natural erectile tissue and replace it with the device. Um, so you'll never be able to have a natural erection again, but you will be able to get a rigid erection pretty much whenever you want. Um, Once surgery is done, nobody knows it's there on external inspection. Um, Generally speaking, it's well tolerated. The most common side effects and complications are postoperative pain or infection, um, mechanical failure, malfunction, or erosion of the device over time. Generally speaking, infection is the thing we worry about the most, but it is rare because we take, many precautions to prevent infection. Um, but there are risks, obviously. So this is kind of the suite of Boston Scientific implants. So we have the AMS 700 with the MS pump, and we have the AMS 700 in the middle with the Tenaccio pump, which is a bit of a newer development. Tends to be a little bit easier to inflate. Um, and we have the Tactra, which is a malleable penile prosthesis, so that kind of stays at one length and girth and is able to kind of be bent out of the way when you're not using it. The AMS 700 is the kind of classic inflatable device where when you're not using it, you can empty the cylinders, the fluid flows back into the reservoir, and it does have a sort of flaccid appearance when you're not using it. So the AMS 700 line has three design options, which is, more variable options than any other implant on the market. The device itself is coated in something called inhibizone, which is it's basically antibiotic. So the device itself is coated in antibiotics and creates a sterile microenvironment to prevent infection. It's designed to closely mimic a natural erection, provides firm rigidity when it's inflated and a natural flaccid appearance when it's not. And these devices have been in use for over 50 years with over 500,000 implants implanted and sold. So here's an example of what inflating the device looks like. So you can see the pump sits in the scrotum, and to activate the device, fluid basically transfers from the reservoir into the cylinders via the pump. And then to deflate the device, there's a button on top of the pump that basically sends that fluid in the opposite direction. So the cylinders become flaccid as the fluid moves back into the reservoir. So, what to expect if you do ultimately like to have this procedure? It's usually done on an outpatient basis. Most patients go home same day or they spend one night in the hospital. The type of the implant, depending on the type of the implant, your incision will either be, above your penis or below your penis, either what we call, the penoscrotal junction if it's below your penis, or it'll be an infrapubic incision if it's above your penis. And generally speaking, we try to only make one incision, but we do whatever's safe. And if we have to make a second incision, usually for the reservoir, we'll do that. It's performed under anesthesia. You're completely knocked out. You don't remember anything. It takes a few days to return to regular activity. And usually you're not inflating the device until about week 4 to 6 after surgery, and you'll start using it somewhere thereafter. So in terms of cost and coverage for penile implant, commercial insurers may cover the procedure if it's deemed medically necessary. Medicare generally does cover penile prosthesis, but coverage may depend on where you live. But generally speaking, we don't do these surgeries until we have a clear plan of how it's going to get paid for. Um, and Boston Scientific does a great job of helping align patients with those resources as well. So if you're interested in knowing, having some firsthand, firsthand reviews of what it's like to have a penile prosthesis, you can take a picture of this QR code, where you can hear patient testimonials, or you could even be, put in touch with a patient who has a device and really pick their brain about what it's like on the other side of having surgery. So the intended benefits of the AMS 700 penile implant. So things we know, 97% of patients would recommend a penile implant to their friend. 95% report satisfaction with their intercourse. And this is the only implant on the market that has antibiotics impregnated into the product itself. Generally speaking, this is an affordable device. It is usually covered by commercial insurers and/or Medicare. It is reliable and durable. It's the only penile prosthesis on the market made with Parylene, which basically reduces fatigue and wear and tear over time. And it is designed to be a long-term treatment. Generally speaking, patients have one device put in and they're done. Um, you know, some some patients will kind of, go beyond the shelf life of the device itself, and that's great because that means they got lots of years and lots of use out of it, and we can always just swap it out for a new one. Um, Again, when surgery is done and you're all healed up, when someone looks at you from the outside, you have no idea that the device is there. And it's designed to feel natural during intercourse. It doesn't feel with it does not interfere with ejaculation or orgasm, and it lets you have an erection whenever you want and for as long as you want. There are, of course, risks, as with any surgery. There's risks of anesthesia. Not every single candidate is a candidate. Not every single patient is a candidate for an implant, but generally speaking, most patients, will be eligible for an implant of some kind. Um, the most common risks are device malfunction and failure relating that could lead to additional surgery, device migration, potentially leading to exposure of the device through the skin, um, where uh, wearing away of tissue around the device, or what we call tissue erosion, can happen. Infection is the one we worry about the most, but infection rates are generally 3% or less. There can be unintended inflation of the device, which generally is pretty minor and well tolerated. Um, and it is important to know that once you commit to having this surgery, like I mentioned before, we essentially destroy your normal erectile tissue in order to put the device in. So you won't be able to have a natural erection again after, or I should say, you won't have a spontaneous natural erection again afterwards. Um, but that's what the device is for. So it's important to remember that you are not alone in this. This is a path that many men have walked. And you may know people already that have a penile prosthesis, and you've just never had any reason to talk about it. Um, you can go to edcure.com and learn more about Boston Scientific offerings and about erectile dysfunction in general, especially in the post prostatectomy, post prostate cancer setting. So here's just some important safety information about the AMS 700 device that I'll kind of let you read on your own. And here's a list of references that contributed to the presentation today. All right, and I'm happy to open the floor to any questions. Thank you so much for your time.